Assalamu alaikum everyone. So today I am here with my new lecture. Basically, it's not lecture. We will discuss few best choice questions, and they are on Vesicovaginal fistulas. A very difficult topic to understand, and especially to solve its BCQs. So we will get an idea of how to understand the BCQs regarding vesicovaginal fistulas. Few are from the management and some of are from the investigations. So we will keep on discussing different topics BCQs, but I guess vesicovaginal fistula is, or urinary incontinence, or overall the fistula topic is one of those topics which has always been a bit difficult to understand, and especially to solve its questions and whenever the topic comes in OSCEs. So we will keep on discussing urogynecological topics specifically through this platform. So yes, starting with the first BCQ. Okay, so question number one is, a 20 years old para 1 plus 0 has presented in Urogyne clinic with complaint of continuous urinary leaking after the birth of her stillborn baby 1 year ago. Her history is suggestive of prolonged labor and delivery by emergency cesarean section. On examination, she was diagnosed as case of vesicovaginal fistula. Which one of the following is the leading cause of genitourinary fistulas in underdeveloped countries? So in my previous lecture, I told you that this is the lead-in questions, and what are the important points that are given in this BCQ. She is a girl of 20 years, her age is 20 years, para 1 plus 0. She has come in Urogyne clinic with complaint of continuous urinary leaking after the birth of her stillborn baby. So this shows that whatever complication occurred, it occurred during her labor. That would most probably be obstructed labor. As we all know, that in developing countries, obstructed labor is a very common complication in our rural areas. Her history is suggestive of prolonged labor and delivery by emergency cesarean section. So whenever emergency cesarean sections are undertaken after obstructed labor, they result in certain complications. So out of which one of the complications is vesicovaginal fistula after prolonged labor, because what happens that after prolonged labor, the tissues at the area where the fetal head is impacted, they get weakened, and the area get necrosed and fibrosed because of the compromised blood supply and ischemia. So in the long term, this complication leads to development of vesicovaginal fistulas. Okay, so the leading question is, which one of the following is leading cause of genitourinary fistulas in underdeveloped countries? The options are cesarean hysterectomy, malignancy, obstructed labor, pelvic surgery, radiotherapy. All of these are the causes of development of vesicovaginal fistulas. But in developing countries or in the underdeveloped countries, the leading cause is obstructed labor. And from this scenario, we can also understand that this scenario is going towards the development of obstructed labor. So yes, the answer is C, obstructed labor. Okay, this scenario is taken from the references from an article in the International Journal of Urology, which was published in 2017. The name of article is Changing Trends in Etiology and Management of Vesicovaginal Fistula. You can easily find its PDF by searching on Google. So you can also download this article, and it is a very nice article. In this article, you can understand the causes of development of fistulas and its management. So I found it very interesting. So yes, the reference is taken from this article. And the explanation is, in industrialized world, the most common causes of VVF are gynecological or pelvic surgery, radiotherapy and malignancy. So this is for the developed countries and industrialized countries. While in underdeveloped countries, the most common cause is obstructed labor. The obstructed fetal head causes massive field injury leading to VVF, which I have explained earlier. Okay, now the next question. A 50-year-old multi-para presented in urogynecological outpatient department with complaint of continuous urinary leaking since 1 year after a difficult abdominal hysterectomy. Examination reveals 2 centimeters vesicovaginal fistula, which got repaired by urogynecologist. Urinary leaking was observed at end of procedure, but diet test was unremarkable. So what has happened? She had a hysterectomy, and 2 centimeter vesicovaginal fistula was diagnosed, and it got repaired by urogynecologist. But still, she had leaking of urine even after repair of fistula, and the dye test was negative. It could not diagnose anything. Her intravenous urogram report done before surgery fails to demonstrate anatomy of ureters. So her IVU, which was done before surgery, intravenous urograms, we got it done before fistula surgery to know the normal course of ureters, or whether they have any kind of problem, or any damage to the ureters has occurred, or whether there are hydroureters. So whatever problem is predicted, intravenous urogram is done for that. So which one of the following would be next suitable investigation for her? Options are Boney's 3 swab test, methylene blue test, cystoscopy and retrograde uretropylography, repeat intravenous urogram, MRI pelvis. So key of this question is C. Reference taken from evidence textbook for MRCOG. The explanation is intravenous urogram is usually not helpful in diagnosing BVF, but is mandatory to rule out uretrovaginal fistulas or ureteric obstruction. So whenever we predict some kind of ureteric destruction or damage, we go for intravenous urogram, and normally it is also done before fistula surgery, though it has no role in diagnosing BVF, but still it is done to rule out if there is any damage to the ureters. So in 12% of cases, concurrent damage is diagnosed as well. If an intravenous urogram has failed to elucidate the ureteric anatomy, retrograde uretropylography should be undertaken same time as cystoscopy and examination under anesthesia. So if IVU is failed to demonstrate any ureteric damage, we have to go for uretropylography, retrograde uretropylography. So this is the answer in this question. The key is C. Okay, so starting with our third BCQ, the scenario is a 25-year-old has presented in urogyne outpatient department with complaint of intermittent urinary incontinence and cyclical hematuria since 1 year after difficult cesarean section due to obstructed labor. So the hints in this scenario is intermittent urinary incontinence and cyclical hematuria, which could be most probably menorrhagia. Hysterosalpingogram findings were unremarkable. This means uterine lining is fine, it is okay. She was scheduled for examination under anesthesia with cystoscopy. So during cystoscopy, filling fluid from bladder flows back through the cervix, means there is some communication between the bladder and cervix. So which one of the following is most probable diagnosis? Cervicovesical fistula, vesicovaginal fistula, uretrovaginal fistula, uretrovesical fistula, or utrovesical fistula. So which of these is the most likely answer? This hint is very strong. Like if you fill fluid from the bladder, it starts coming out from the cervix. So most probable answer is cervicovesical fistula, and the uterine lining is fine. This means utrovesical fistula, it is excluded. So let's see the key. So the answer is A, cervicovesical fistula. Reference is taken from Shaw's textbook of operative gynecology. Vesicocervical fistula is a rare complication of cesarean section. It can present immediately after cesarean section or sometimes later. Presentation could be continuous, intermittent, or transient urinary incontinence. It depends upon the location of fistula. Whether it is located below the cervical os or above the cervical os. Other symptoms may include menorrhagia when fistula opens above internal cervical os. This is due to pressure difference between bladder and uterus, which is around 130 to 160 centimeters of water during voiding phase, especially during the menstrual cycle phase, the pressure of the uterus. Continuous urinary leakage occurs when fistula opens below internal cervical os. So if it opens below internal cervical os, then there is continuous urinary leakage. If it is above cervical os, then she could experience menorrhagia, which is in our case. Diagnosis should be confirmed with the pelvic examination, cystoscopy, cystography, and cystourethropy. And surgical management is preferred for vesicocervical fistulas. Okay, so coming towards question number 4. A 50 years old multipara underwent difficult abdominal stectomy 3 days ago due to heavy menstrual bleeding. She had previous history of 2 laparotomies due to ovarian cyst. Bladder was reflected with difficulty during surgery. Post-operatively, she had urinary incontinence despite catheter insertion. The consultant gynecologist examined her and confirmed 2 centimeter vesicovaginal fistula with clear margins and healthy surrounding tissue. So the hints in the scenario, you have understood she has a vesicovaginal fistula, but the fistula is a healthy fistula with clear margins. So the lead-in is, which one of the following will be preferred management option for her? What could be done for her right now? 3 days are passed, she had a hysterectomy. So what can be done? Catheter in situ for 21 days, call after 3 months for repair, leave for spontaneous closure, prescribe antibiotic cover for a week, repair within a week. Okay, so all of these options are correct. The catheter can be left for 21 days for spontaneous healing, but the fistula is around 2 centimeter fistula and with clear margins. So call after 3 months. We call patients after 3 months whose surrounding tissues are weak and there could be some kind of slough or fibrosis. So these patients are called after 3 months. Leave for spontaneous closure. This is a large fistula to leave for spontaneous closure. The fistula should be less than 2 centimeters so that it can be left. Or antibiotic cover, we have to give it anyways, and repair within a week. So two options which are confusing are A and E. If we leave catheter for 21 days, it could heal spontaneously, but there is a chance that it might not. So if it has clear margins and healthy surrounding tissues, so it is better to repair it within a week. E is E. Tissue necrosis, prior irradiation, infection or urinary extravasation all mandate delay, usually 3 months before surgery. Most reconstructive surgeons would now accept that a clean traumatic simple vesicovaginal fistula or ureteric fistula may be treated almost at once provided it is diagnosed within a week of surgery. If the fistula is diagnosed within a week of surgery, it should be operated immediately. So the reference is taken from Shaw's textbook of operative gynecology. Okay, so the scenario is a 65-year-old woman presents in Urogyne outpatient department 1 month after anterior and posterior colporrhea. She complains of urinary leaking while coughing and burning micturition. She feels she did not have any of these symptoms before surgery. So the hints in this question are stress incontinence, urinary leaking while coughing, and UTI. Out of the following options, what could be the possible causes of her symptom? Okay, so whenever there is complaint of stress incontinence, this means there is something wrong with the bladder neck. And the fistula which has developed or any other problem which has developed, it is involving the bladder neck area. So what could be the possible cause? A. Fistula involving bladder neck. B. Fistula involving upper part of urethra. C. Fistula involving lower part of urethra. Wide urethra, urethral diverticule. So let's see what is the answer. So the answer is A. We were right. The reference taken from evidence textbook of gynecology. The explanation is urethrovaginal fistulas most commonly develop after anterior repair with or without vaginal hysterectomy. They can also develop following urethral diverticulum repair. Symptoms may vary depending on the site of fistula. Means it is involving the bladder neck, it is above the urethra or lower down. With the fistula higher up in the urethra, there may be continuous incontinence. Fistula near bladder neck may present with stress incontinence and recurrent UTIs. One lower down may cause symptoms of spraying of urine at micturition or post-micturition dribble. So these symptoms, you must remember the symptomatology according to the site of fistula development at urethra. Almost all patients need surgical correction in specialist care. Okay, so this is all from this lecture of best choice questions from vesicovaginal fistulas. I hope you must have understood or it has become a bit easier for you to understand solve BCQs of VVF, which mostly comes in FCPS Part 2 examinations, and those who are going for urogynecology subspecialization. Jazakallah. Thank you so much.